you to CARPHA for inviting me. I represent the Pediatric Emergency Department at Eric Williams Medical Sciences Complex in Trinidad, and also I've been asked to mention that I represent UV as well. So for us, our objective really was to better understand the clinical profile of chikungunya, and in particular to better define the clinical manifestations of infants and young children, particularly those under the age of 5. We knew that this was important, partly because it was showing a progressive march throughout the Caribbean islands, but in particular the first confirmed case in an adult in Trinidad was reported on the 14th of July 2014, so we knew it was only a matter of time before we saw it in our pediatric population. Just to tell you a little bit about my department where I work, the Pediatric Emergency Department at Eric Williams Medical Sciences Complex is one of only 2 dedicated specific pediatric emergency departments in the English-speaking Caribbean. The other is in Jamaica. And we're quite a busy unit. We see approximately 60,000 pediatric attendances per year up to the age of 16. And a number of facilities which allow us to look after our patients, including a 7-bedded critical bay and also a 10-bed observation unit, which allows us to keep an overnight look at our patients for up to 24 hours. That became particularly handy during the peak of the chikungunya epidemic that we experienced. We support a lot of education and training, both for undergraduate and postgraduate programs, in particular the diploma and DM programs in emergency medicine and pediatrics. So we knew that it was coming, and as a department we knew we had to take steps really to prepare for the onslaught of chikungunya. So we took a number of steps. We held a series of staff sensitization lectures, both for our medical and nursing staff, really so that we understood better what had been described about chikungunya, what was the typical manifestations that were described, but more specifically, what were the atypical, what were the concerning factors. So when would we expect that patients were more likely to be unwell? We knew it was more related to extremes of age, for example, particularly our neonatal population and extremely young population. Those who had underlying chronic medical illnesses, for example, were also another concern. And we wanted to increase awareness so that people thought about it and knew to consider it as part of the differential diagnosis. We also developed patient information leaflets and advice leaflets for our families because there was a lot of concern, public concern. There was some information out there in the public media, and people had a lot of questions for us as well. We developed clinical management protocol guidelines for our doctors in the department, which guided decision making, and particularly stressed the importance of low thresholds for admission for the extremely young, and automatic admission for at least an overnight stay for patients who were less than 6 months. And we actually did develop a pediatric emergency department surge management plan in anticipation of increasing numbers, and I have a slide that does show the impact on our attendances. We liaised with the public health laboratory to facilitate more rapid collection of samples for chikungunya PCR sampling, but to try and see if we could accelerate the return of our results, and that's an issue we talked about. And we were able to have some collaboration with CARPHA, who very kindly came and did a presentation for not just the hospital staff, but the wider regional health authority staff. It became a little bit more about Ebola at the time, but primarily it was about sensitizing our workers, both within the hospital, but in some of our outreach health facilities, really about new and emerging illnesses. And our first confirmed pediatric case was on a sample that was sent from the Pediatric Emergency Department on the 1st of September 2014. So we did know a lot about the typical clinical manifestations of chikungunya, as we've talked about, as described by CDC, things like fever, polyarthralgia, headaches, myalgia, back pain, some gastrointestinal symptoms, polyarthritis, rash, and conjunctivitis namely. We were aware that there were likely to be some atypical manifestations, and things like neurological and ocular and skin manifestations also being described. But what about the experience in infants? Probably one of the biggest studies we were able to come across was in the Indian Journal of Pediatrics, and published in 2009. And this was a prospective study in Kerala in India. And they looked at specifically children under the age of a year, 56 infants, and followed them up really with IgM testing at 7 days post the onset of fever. They described clinical signs as the onset developed, and they followed them up on a daily basis until the resolution of symptoms. So the most common features that they described were fever, over 101 degrees Fahrenheit, which roughly correlates to 38.5 degrees Celsius. Seizures, but interestingly, the seizures happened in 39% of patients, but about 24% of patients actually had atypical febrile seizures, defined as either multiple seizures within the same illness, or prolonged seizures or potentially focal seizures. Irritability, described in about a quarter, lethargy, poor feeding, edema of the lower extremities, diarrhea, acrocyanosis or blueness of the extremities, typically the hands and feet, and skin manifestations such as erythema, peeling, maculopapular rash, and vesicular bullous lesions that have all been described. So in our experience, we had 45 children who presented between the ages of 0 to 5 years who came to our pediatric emergency department within the period of the 1st of September 2014 to the 13th of November. And that 10-week period was chosen because it coincided with the peak of our attendances and clinical diagnoses. I'm aware of, we've had 17 subsequent patients who've also tested positive. That takes us up to a total of 62 patients at this point in time. With the 45 patients that we got data on, we then performed a retrospective review of the emergency data and really looked at their clinical presentation in more detail. And all of our patients tested chikungunya virus positive on reverse transcriptase PCR. So I wanted to show you the impact of ChikV on our PED attendances. The graph shows a few things. Let me just see if I can get the pointer. It's all working. Okay, so the blue bars on the graph show the number of weekly pediatric emergency attendances over that 10-week period in 2013. And the red bars show the weekly attendances over the same period in 2014. And the line, the red line on top, shows the number of chikungunya positive cases that were confirmed on PCR. And this would just be the tip of the iceberg because for a number of reasons we were getting several more cases who were either mild, or didn't need admission, turned out to be other features as well. And the public health laboratory had confined PCR testing to patients who were under the age of 5. So we had older children who potentially had chikungunya who we didn't perhaps have PCR results available for. But what was really striking is, coinciding with that, is a real peak in the red blocks that particularly spike around weeks 38 and 39, which was really the peak of when we were starting to see patients. And that coincides with an increase of about 43.4% in pediatric emergency attendances. So we were really being inundated. Of our 45 patients, our patient demographics were roughly equal male and female, 51% female, 49% male. Our patients were presenting to us pretty early in their illness. The average duration of illness was 1.4 days at the time of presentation, with quite a large range, 0 to 8 days. 73.4% of our patients were under the age of 1 year. And if we look at our patient demographics by age, what's quite striking is that certainly the vast majority of our patients, as I said, 73.4% are under the age of a year, but half of our patients, essentially 46.7%, are under the age of 6 months, and we had 20% of our patients were neonates under the age of a month. And what was interesting is the Indian study, only 7% of their patients presented in the neonatal period, so we definitely were skewed towards the younger end of the age spectrum. And these were the sorts of clinical features that we came across. Significant number of patients, nearly 100% had fever over 38 degrees Celsius. Pain and limb swelling was also quite common. Rash, for us, was mainly maculopapular. We had a petechial rash in one particular instance. Seizures, and in a lot of these cases, these were atypical, multiple seizures within the same illness, prolonged seizures, for example. Parents reporting that babies were handling poorly and were irritable. Gastrointestinal symptoms such as vomiting and diarrhea. Respiratory symptoms, actually, not that well described in the literature. We were getting cases of rhinorrhea, cough, and increasing tachypnea in about 16%. and a case of quite severe coagulopathy in one patient. So I thought it would be helpful for us to go through just some brief clinical vignettes which explain a little bit more of the sort of range of potential presentations we were experiencing. So our first case was a 9-month-old female, previously well, and she presented on day 1 of her illness to the emergency department with a history of fever, irritability, and nasal congestion. Her mother reported that she was repeatedly screaming on being held and seemed in pain. There were a number of ill contacts in the neighborhood who had classic symptoms of chikungunya. And on presentation, quite strikingly, she was febrile and looked unwell. Her temperature was 39.5 degrees, and she was quite markedly tachycardic as well. So she had a full sepsis screen, which for us includes cultures of urine, blood, and CSF, cerebrospinal fluid, sorry. And we started on empirical antibiotics, IV fluids, and saline nebulizers for her rhinorrhea and nasal congestion. She got admitted to the ward where she completed 5 days of antibiotics. Interestingly, all of her cultures were negative, and she was well at the point of discharge. About 6 weeks later, her PCR result came at us, and she was chikungunya PCR positive. The clinical case 2 is a 2-year-old male who was also previously well, no underlying previous illness. Presented on day 2 of his illness with fever. His mother reported a lot of body pain, rigors, poor feeling, and a maculopapular generalized rash. He had 2 febrile seizures within the space of 12 hours. Each lasted 5 minutes, and he recovered fully. There were no reported ill contacts at home. On presentation, he was also febrile, temperature was 39 degrees, and he had a rash as previously described. He had a lot of conservative management, advice to his mother on fever management. His fever responded to paracetamol. He was kept for an overnight admission, really to encourage oral fluids and hydration, which we found to be particularly important in the younger patients. Admitted to a holding bay for overnight stay, and discharged with an outpatient follow-up plan, and in particular plan for an EEG to investigate his seizures further. And again, 6 to 8 weeks afterwards, his chikungunya virus PCR result came at us, and it was positive. Okay, so clinical case 3 is a neonate. This is an 11-year-old male infant, the product of an uneventful pregnancy and delivery. Interestingly, his mother had chikungunya symptoms as well. And he presented with a 2-day history of fever, nasal congestion, poor feeding, and a rash, maculopapular again. On presentation, he was febrile, temperature was 38.5 degrees, quite tachypneic and tachycardic. And one of the interesting things we found was that the tachycardia was often out of proportion to the fever. So we would have babies with heart rates of up to 200, 210 beats per minute in this particular case. He had a full sepsis screen, started on first-line antibiotics and antivirals. His cerebrospinal fluid did suggest viral meningitis with increased lymphocytes, however, hence the acyclovir. But he developed increasing respiratory distress on day 2 of his admission, required intubation and transfer to the pediatric intensive care unit, where he had a very complicated course. He required inotropes for hypertension. He developed a disseminated intravascular coagulopathy together with thrombocytopenia and required transfusions of PAC cells and fresh frozen plasma. He was ventilated for a total of 14 days in the pediatric intensive care unit. Discharged after 21 days in patient stay, and during that time he had required 14 days of acyclovir, 14 days of broad-spectrum antibiotics. His cultures, CSF cultures and urine cultures were negative. His blood culture grew a staph hominis, which was felt to potentially be a contaminant. But more importantly, his chikungunya PCR came back positive 8 weeks after his admission. So, lessons learned for us, well, there is an obvious need for clinical suspicion. So I think our staff worked really hard to make sure that there was increasing awareness, good knowledge. We really understood a bit more about what we were potentially going to be faced with before it came. The real importance of supportive care. For one of the things that came out of it is like real close attention to monitoring, and in particular emphasis on hydration and fever management, especially in the younger population, is particularly important. Training and education for staff and parents and families. Negotiating issues with testing and timeliness of results. As we saw, our patients presented to us pretty early, so very often it was within the first 5 days of illness, which meant that IgM testing was not necessarily an option. PCR was helpful, But what was happening is that because of the timeline for the return of results, it wasn't really a tool that was clinically guiding our management initially. So while it's extremely useful for us to help describe the epidemiological picture that we were seeing and to understand the clinical manifestations, it didn't really help to guide us in the acute management. And one of the things that would be really helpful for us is perhaps looking at more timely access to results, and that's something for discussion. Surge management planning was helpful for us, and particularly we were suffering from increased bed pressures and lots of increased attendances to the emergency department. And the use of our overflow units came in really handy, particularly our overnight stay observation unit. And the benefits of collaboration, both within the department but also outside agencies, such as our public health laboratory and CARPHA. And in summary, we knew there was a relatively new phenomenon for us in the Caribbean with a very heterogeneous presentation. There seems definitely to be a different spectrum of illness, particularly in young children and infants. Lots of emphasis on close monitoring and supportive care, particularly in the younger patients, but really the need for further research and ongoing collaboration. And our message for our doctors and nurses in our department is always think about chikungunya when faced with a patient. So thank you. That's my contact details if anybody is interested in getting in touch. And I put that up there really as another vignette. I mean, this was off the internet, spelling of ChikV noted. But a lot of our patients did actually come in with a story of being closeted indoors with the mosquito coils and everything else going at full steam. And it's a total aside in answer to the previous panel discussion. We have anecdotally seen patients with asthma coming in who had exacerbations of asthma, mainly linked to being locked in beds with the cigarette coils and everything going at full steam. So that's a whole other study to be conducted. Thank you.